Yes.
I saw that.
was telling me, Sophie is there.
Yeah.
Really?
Yeah.
You know.
I saw that it's a lot of changes for you as well. It's growing. Sorry, I'm just.
You left before. The move.
Yes.
Yes,
because you moved 2 years ago.
Yes.
You left in 2019.
Yeah. Okay.
So it was great, very great to see you.
Okay. Thank you for coming. I can put my things outside.
Yes. No. Je prenais pas vraiment plaisir. C'est bien, ouais, mais l'époque, moi j'ai pas envie de dire. Enfin, j'étais très. Non, mais tous les autres parlaient en fait. Je pense qu'en fait on n'a pas choisi. Moi j'étais dans un groupe, ils m'ont mis dans. J'en ai fait l'année dernière. C'est pas longtemps. Je suis pas débutante. Très débutante déjà. C'est pas tous les. C'est pas comme tu voilà. Et donc on me mettait dans ce groupe-là. Et j'ai dit bah non, ça sert à rien, je vais faire 2 années à même chose. On m'a regardé avoir des chiffres avec plus. Mais sauf qu'il n'y avait pas de. Il n'y a pas d'intermédiaire. Il n'y a pas d'autres personnes à connaître. C'est déjà des encore plusieurs dans ce groupe. Je sais que oui, voilà, donc je me suis dit, non, c'était vraiment reculant dans quelque chose de ça. Et ça me prend beaucoup de temps. J'adore
So I would like to welcome you all today for a lecture today on epidemiology and prevention. I'm very happy to see all of you here besides the holy event we are facing today. So we are very pleased to have an event in this month which are dedicated to childhood cancer. And I'm very pleased also to have Eva amongst us, and I'm really happy that we had already a nice evening yesterday, and we're trying to make the best out of the situation we had today. So thank you very much for coming, and I let Aline introduce you to everyone, and I also welcome everyone online. So thank you for joining, and welcome to Luxembourg.
So, good morning. I'm very happy to introduce Dr. Eva Steliarova. She said she speaks in French, the surname Foucher. She's an expert in cancer research, and she's especially working with cancer in childhood. She's from IARC, and I will leave the floor for you, Eva. Thank you so much for accepting and for being here today. We are very happy to have you here with us today.
So I also thank you for the invitation. I'm very pleased to be here, and especially it is unexpected to have my name connected with the folk forever in your mind. So Aline asked me to give a 3 hours presentation on childhood cancer, so let's start. So I'm working in International Agency for Research on Cancer, which is agency which belongs to World Health Organization in cancer surveillance branch. So we work a lot with cancer registries. And recently I became also a childhood cancer team leader of the agency. And this is in connection with global initiative for childhood cancer that I will talk about soon. So, what is childhood cancer? We define childhood cancer as all cancers that occur in children. So it's defined by the age of the host. And well, we have different definitions. If it's somebody less than 1 year old, it's infant, then children 0 to 14, adolescents. And very recently now we call childhood cancer even 0 to 19 years of age. Because the adolescents were found as, falling in between children and adults. So there is quite an emphasis on adolescents, and in clinical world also the pediatricians embrace also adolescents care. So, and as you can see, childhood cancer is also very different in the way the cancers present. So these are cancers of adults. I don't know if it's doing anything for adults. And you can see that some 80% are carcinomas, and here carcinomas represent 5 to 10%. So the composition of tumor types is very different in children than in adults, and it's up to 19. If we go even to lower age groups, it would be even more different. So, and it is also rare, as you know, but how rare is it? So, what do you think? You have several options. 1% of total cancers, 5%, 10 or 15? What do you think? Sophie, she knows because she's looking at the age distribution.
No, 1.
1%.
Very good. Yeah.
Yeah.
Okay. So let's see, 1% in high-income countries, and it's even less probably, and 5% in low-income countries. So here, this is based on data from Globocan, which are estimates for the global cancer burden. So you can see on the world level, it's about 1%, but we can see that in low-income countries we have larger proportion of cancers in children, because there is a larger proportion of children in the population. And you might know the age distribution of, or age-specific rates of cancer. So in childhood, there are, you can see even from here, it's like 100%, 100 times less than in older adults. And these are data from Sweden and India. Comparison. So, childhood cancer on the global cancer control agenda. Maybe some of you remember that there was a high-level meeting in UN in 2011, and we were very hopeful that there would be changes for cancer. And there were, because they accepted a memorandum on fight or control of non-communicable diseases, and this was then translated to a list of resolutions in next year, in 2012, in WHO, where they said, yes, we are going to do something to fight cancer. And then in 2013, there was a follow-up meeting, and in that meeting, all cancers were supposed to be fought against, except for children. Because as you can see here, from non-communicable diseases between ages 30 and 70. So explicitly, childhood cancers were excluded from this. So no childhood cancer control until 2018 on the global level. But then in 2018, WHO launched a global initiative for childhood cancer, because it was, after some years, several years of lobbying, and this initiative is supported financially by St. Jude. So these are the director of WHO and the director of St. Jude. So they launched this initiative, and the aim is to attain 60% survival of children with cancer by 2030, and with this, they hope to save 1 million lives. So now this initiative is moving forward, and there is a cure-all framework to describe all the different aspects of this initiative that should go ahead. And these are based on this assumption that, or observation, that more than 80% of children in high-income countries will survive cancer, and it will be less than 30% in low-income settings. So, as you could have seen maybe, but that is a little bit enlarged. So a very important aspect is also to strengthen cancer registration, because we realize that we do not have the data, and even this less than 30% of children that survive is not really based on data. It's assumption on some fragmented information. So yeah, when you speak about cancer registries with pediatric oncologists, there is some, very often there could be some confusion whether we speak about hospital-based registries or population-based registries. So they are sort of complementary. Hospital-based registries collect data to evaluate care. Population-based cancer registries, they collect data on the whole population, so the results of this collection will be possible to apply to the total population. For example, hospital-based cancer registries cannot calculate incidence rate because they do not know what is the background population for their patients. And we also need to calculate population-based survival, which is needed for Global Initiative for Childhood Cancer, to know how many or what is the proportion of children that survive. And this population-based survival, it includes not just treatment, it includes also access to care and supportive care, adherence to treatment, and so on. So it includes many other factors than just treatment. So, but the problem is that there is a very small coverage of world child population by population-based cancer registries. So these percentages show the coverage by continent, and we can see that it is very low in, for example, in Africa. For children it's about 5%, for adolescents even less. Smaller proportion of population that is covered by cancer registries. So overall, despite of this high level of coverage in Northern America, relatively high also in Europe and in Australia or Oceania, overall it's only 13% of population of children that is covered by registries that can provide comparable data. Okay, maybe there are more registries, but their data may not provide sufficient detail or are incomplete, etc. So these were the registries that were included in the International Incidence of Childhood Cancer, Volume 3, and it refers to year 2010. So because of that, this lack of coverage is not just for children, it's in general, and IARC has set up this global initiative for cancer registry development about 10-15 years ago, which is based on country leadership, regional focus, and global coordination. So they are working in 6 different hubs to support countries that want the developed cancer registration. And then St. Jude Children's Research Hospital, they are, their aim, well, they established program St. Jude Global, which aims to ensure that all children get proper treatment if they get cancer or other disease. So we put our forces together, and this gave us the Child GICR collaboration, which is now in the 5th year of running, and I will tell you a little bit more about it. So we have 3 working streams: implementation in countries, education, and research. So implementation, we are at the moment working or trying to work in 4 countries.
target countries, Mexico, South Africa, Georgia, and Vietnam. This is to first examine the needs of the population, and then see who are the partners, try to establish collaboration, and have a workshop, and then follow up. So, of course, this is not a very smooth process because there is a lot of political considerations and political fights that have to be done before this will go ahead. In education part, we have developed a masterclass. So this is on the picture. Most of those people who are on the pictures are our new trainers in childhood cancer registration. So there are 20 of them, and in 2021 we together developed these 7 modules of teaching material, which now we use for other courses. And we had some already, 3 courses, one in Chennai, India, Hanoi, Vietnam, and the last one was in Tbilisi, Georgia, and we are just organizing a new one in Caribbean, which will start beginning of October. So all together with the trainers and the other people who were trained by these trainers, we have about 100 people around the world that got some education in childhood cancer registration. And here they are, happy participants of the 2 first courses. And this is how they think about the course. So as you can see, the evaluation was very good because most of them liked the course, and about 60% would like to be involved in this Child GICR initiative or help to support cancer registration in children. So we also do some research studies. For example, we are looking at data standards, how to register CNS tumors, hematopoietic neoplasms, hospital-based cancer registries, how to develop also registration there, because their data are useful for population-based registries. And then we also were looking at data sharing. And we are looking also at health economics. So we had 3 sort of areas. One is financial toxicity for the families and children, then cost of childhood cancer registration, which we developed together with the WHO, and what is the financing mechanism. So some of these tasks are just starting or will be starting, others are quite well developed. So for example, we have asked the registries whether they register non-malignant CNS tumors, because we know that this is not standard registered in all registries. So as you can see, we invited those registries that participated in IICC 3 because we thought that we also have their data, so we can compare their response to the questionnaire with the data. So this only shows the questionnaire. We had 150 registries that responded, and out of them about 1/3 does not register non-malignant, and another third another part, they register only some of them. So that means that the incidence rates that are calculated from these registries are not very comparable across these registries. And then we also asked why they don't register. So these are all the reasons that they provided. So they either do not have enough financing, or it is a problem of legal issues. They do not have proper software and different other reasons. So the idea is to try to encourage registries to register non-malignant CNS tumors, because they are important to be included in incidence rates, because they create also a lot of, they need to be treated, and if not, then they can have a fatal outcome. So another work is led by St. Jude. This is classification of pediatric CNS tumors, where they try to classify them according to outcome, because in childhood cancer classification that we use for epidemiological data from registries, these are based mostly on the origin of these tumors. Here, the classification, this is work in progress, so it's nothing yet, it is not a recommendation, but the classification looks like this if they look at the results of treatment. We are also trying to move something within GDPR because it is very restrictive that we cannot receive data for international studies as we used to before. There are many barriers from the registries, and it's because they are, for example, they are scared to give us the data, or we get data stripped of dates or other important information. So this is just overview from review, which is in progress, and showing how this GDPR impacts research, health research in general. But for childhood cancer, this is sharing data is especially important because these data are rare. 147 cases during 9 years of registration in Luxembourg. So you cannot get really very powerful statistics out of this. So we need to put data together to do international studies so that we have a lot of cases for analysis. So another thing that we were looking at, this is again with the leadership from St. Jude, on financial hardship of families that face childhood cancer. And in this was also a review of different studies around the world to compare what is the impact on financial status of the families and also on other factors. And it is clear that it is disastrous in low or middle income countries, but even in high income countries, very often this type of disease can lead to impoverishment of the families. So it's an important issue to discuss. So this is our website and the team, a mix of IARC and St. Jude people, and it's not quite up to date, but well, just to give you an idea, and you can learn more from the website. This is even before Child GICR started, we have this International Incidence of Childhood Cancer that collects data from around the world, from all the registries, also from pediatric cancer registries, which are not included in the other flagship publication, Cancer Incidence in 5 Continents. So this is first volume, second volume, and the third volume is still not published. We are waiting for the editor of English language to get this moving. Yeah. So, but there are some interesting information. There is in this tab on classification. So this is the classification of childhood cancer that we used for these data. And then in the results, you can find a lot of tables showing incidence rates by country, by registry, and by tumor type. So, and based on those data, we selected subset that was for 10 years of data that were most commonly covered by the registries that contributed to this volume. And this is the result. Well, these are not new results, but for now, they were not superseded by any other studies. So we have grouped all cases into, according to where they come from, into these different regions so that we can compare incidence in different parts of the world. And we can see that the most common are leukemia, lymphoma, and CNS tumors, but there are quite big variations. For example, Sub-Saharan Africa, the rate of leukemia is very low, as well as CNS tumors. Similarly, in South Asia, also leukemia is less common than in other regions. And here we can see the other tumors, the less common neoplasms, that also we can see some variations. And you can observe that usually countries or areas with high income, they have higher rates, overall rates, and also rates by different tumor types than those that have lower income. So we don't know exactly how to explain all these differences, and we would need to go to each cancer type specifically. One part is maybe they are not diagnosed, maybe they are not registered, maybe there are some tumors may be shifted to unspecified tumors from leukemia or specified. So we don't know exactly what it is, but there could be also some either genetic background or environmental exposures that can play a role. Then how much of that role can be explained with these risk factors? That needs to be studied in other studies. Mostly case control, unfortunately, it's for childhood cancer. So, and we have also compared how the rates changed between the two volumes of international incidence of childhood cancer, and we can see that for most regions there was a significant increase in incidence, and this is confirmed or seen also in other studies. So there is always small increase in childhood cancer incidence happening since the 90s. Again, what is it? Is it better registration or is it changing exposures? So again, that needs to be investigated. Okay, and because as shown before, cancer registries cover a very small proportion of total world population of children, there are many estimates of the new cases that occur annually in children. So as you can see, depending on source, it can vary from simple to double. Globocan, these are the Globocan estimates, they are most conservative, and for 0 to 14, for example, there is estimate that it's 200,000 children with cancer per year. And here in this study, they estimated almost double because they consider that there are many children, up to 43% of children with cancer, that are not diagnosed, so they are not included in statistics, and but they sort of enlarge the numbers because of various assumptions that they used in analysis. So that's for incidence. Now, you probably know that childhood cancer survival improved a lot over the past 50 years. We had, for all cancers, less than 30% 5-year survival. Now it's more than 80%. These data are based on the UK, but we can see that also in the more recent times, there were some improvements for different regions of Europe. These are Eurocare study results, and also by tumor types. Although there are many tumor types where the improvement over the most recent period were not significant, but it's at least relatively favorable trend. So when we look at other regions in the world, so far, well, there is Concord study that is trying now to produce estimates of childhood cancer survival for all countries that can provide this data. In the meantime, we just checked what is published, and there are a few publications. We put almost all of them there, except those that overlapped. And again, the colors differ by continent, and you can see that there is again very strong relationship between income level of the country and survival. So it just confirms that the children in low income settings, they have much lower survival because of access to treatment and then quality of treatment and so on. So, but in high-income countries, children survive, and then they become survivors, and these survivors are subject to risk for their health, future health. So we know, for example, that they have increased risk of second primary tumors compared to general population, and this risk could be well, several times higher. And this is why we propose this study, Cancer Risk in Childhood Cancer Survivors, Understanding the Causes to Target Prevention. And this study has 4 objectives. So to estimate prevalence of childhood cancer survivors in Europe and also elsewhere if we get the data. Then quantify risk of second primaries, assess their determinants. I don't know why it's okay. And the last objective was to develop a guideline for registries how to collect this data, because there are some questions, as you will see later. So the study is funded by Children with Cancer. One study that we did was to review literature on prevalence of childhood cancer survivors in Europe, and overall, out of I think 900 studies, there were only 13 that were describing really prevalence of childhood cancer survivors, at least partly. And in these studies, we saw large differences in the results, how many there are survivors. So it varies, as you can see, between 450 to 1,240 persons per million in general population. And it really depends on what is the definition of underlying population, what is the age at diagnosis, age at prevalence, what are the cancer types that are included in this evaluation, the length of follow-up period. So there are many factors, so these studies are not really very homogeneous. And well, this was the conclusion from this review. And because of that, we are working on trying to develop method that could evaluate this prevalence in harmonized fashion. So our colleague Andrea Gini, he developed this POX model, which is prevalence of childhood cancer survivors, which is based on Markov model. So with some data that we have, we can impute it to model that will then estimate the number of prevalent cases, and they were the estimates that are here were compared with estimates provided by Stat, where the data are individual on individual level. These data are grouped, and as you can see, the results were very comparable. So then this method is being used to also estimate the prevalence in other. This was done on one data set in Netherlands, where we had good data. So we could do both methods. Then, because it works well, we assume that it is going to work well also in other countries. So we are going to, well, it's in progress to prepare prevalence of childhood cancer survivors in Europe. Yeah, so, but what we can say for this CRIC study is, you can see, this is comparison of collaboration on CI5, contribution by cancer registries, this is any age, and in CRICs. And it's quite striking that for CRICs we have maybe 20% of those registries that contribute to CI5. So yeah, it's a little bit disappointing, and well, we have several explanations for this. Maybe it's because childhood cancer is usually, because it's small fraction in a registry, people are not so interested in investing into this. The study design is quite complex. We asked for a lot of data and detailed information. So data may be also not available for what we want to do in the CRIC study. So there are many factors that might influence this, but still we do not have all the data that we would like to have. With what we have, we try to estimate the second primary neoplasm risks in childhood cancer survivors, and this is another colleague who is working on it. And as you can see, this is the number of cases overall that we have had for registries in 6 countries, 38,000 cases, childhood cancers, first primary, and out of them, about 3% developed second primary. And this represents standardized incidence ratio of about 5. That means that childhood cancer survivors have 5 times higher risk to get second cancer compared to general population who did not have the first cancer. And also the absolute excess risk per 10,000. So in 10,000 people, there would be 20 more new cancers in survivors compared to the general population. I mentioned also these guidelines or recommendations for cancer registries. Apparently guidelines is much stronger word, so we can call it recommendations, but this was in the proposal. So we need to maybe re-evaluate, at least for survivorship studies, how should the multiple primaries be defined? Because at the moment, the second primary is not defined by time when it occurs. So if it occurs in the same if it's the same cancer reoccurring or whatever in 5 years after the first, it's not counted as a new cancer in the registry. So these are the current recommendations. So we need to re-examine, is this desirable in survivorship research? Because for survivors, it is important to know, even if it's recurrence, that they might have this risk of second cancer. Cancer registries are interested in, knowing what are the reasons or causes or, the frequencies of occurrence. But this is not the same for survivors. So, and there are several other questions that need to be discussed and decided how to deal with this. So this is just the team of CRIC study, internal, external collaborators. We also have former survivor of childhood cancer and a parent representative on the scientific advisory board. So, and we have the website where you can learn more about it. So I will finish soon. This is what we are going to do or what we start doing. Well, maybe you know this website, Global Cancer Observatory. It provides data, a lot of data on everything about cancer, but it is not specific to childhood cancer. So as you can see, this is for all ages. We can see the 10 top cancers for all ages. And when we look at age 0 to 19, we can see some, but it's not really very explicit. We cannot see the childhood cancers that we mentioned, neuroblastoma, retinoblastoma. They are not there because, of course, it is defined. These tumors are defined by International Classification of Diseases, which is adapted to cancers that occur in adults. And then, if we look at age 0 to 4, it's even more I wouldn't say useless, but it's less of interest because, for example, we have vagina here as one of the top 10 cancers in children, but this is not really correct reflection of what of the cancers that children get. So what we want to do is to develop a similar online resource where we could put the data on incidence, survival, mortality, prevalence, risk of second primaries, and also childhood cancer costs. So it is a lot of work, but we have some data. The data that we do not have or cannot generate, we would take from publications. And so this is what we want to do next, or that we are starting to do. So in summary, some things to give you some sort of box. So childhood cancers are different from other cancers or cancers in general, because they are different, but they represent very small proportions. So they need really to be focused at. If you want to represent childhood cancer, okay, you have to have a dedicated person, dedicated work, dedicated study for that, even data collection and so on. So as you have seen, childhood cancer burden differs a lot around the world, and it is often these differences in patterns of incidence, survival, occurrence. It often is related to income level in those regions or countries. And in addition, in low and middle income countries, we have very little information. So we don't even know the extent of this gap. So of course, then we try to do estimates to say, okay, we know that there is so many cancers around the world, but these data are really, in some cases, really just guessed, because they are estimated using data from other countries. And sometimes in Africa, for example, if we have only 5% of population covered, these 5% determine what is the incidence in the whole continent. So, so the registries, to collect population-based data, they need support. And because registry cannot be established for 5 years or 2 years or whatever, it is long-term, never-ending story. So they need to be supported sustainably, and that would come probably from government, because government should have interest in knowing what is the cancer burden in general and in children as well. And then, because childhood cancer is rare, we really need to work together and in collaboration, share the data so that we can make some sense of them. And for registries, so as mentioned already, really we need to also put focus on childhood cancer, because even in GICR, for 10 years of existence before child GICR was set up, there was no specific focus on childhood cancer. So unless we really concentrate on that, we would not do much for childhood cancers. And because they are rare, we need to be extra careful to have everything right. Because if you have one mistake among 5 cases, it is 20% difference. So even though they are rare, they require a lot of work. We need to ensure correct linkage of information on individual patients and cancers over time. So I don't know about these pseudonymization methods, whether they can assure it, because women get married, they change name, people move, they migrate. So I don't know, without, we need really good identifiers to be able to link first cancer, second cancer, and for example, mortality data and so on. So when registry provide data to international study, it's sure 100% that their data will improve, because we are learning from each other. And I can prove it, but I didn't put it in this presentation because of time. Yes, so and of course we are very happy that even for those registries that already exist and they collect data, because without their work and effort, we would not be able to even show what we show today. And for example, Global Initiative for Childhood Cancer also, it's based also on the data that are collected by registries where they are. So, and this is just a statement. Okay, it's a small proportion childhood cancer, but it is a whole world for the cancer patients. So we need to invest into this research. Thank you very much for your attention. So this is our beautiful new building, 2 years new, and there are some links for more information or contact. Thank you very much.
Thank you very much. Well, thank you you, Eva, for this excellent presentation, but also for this incredible work you and your team are doing. We are very grateful for that. Maybe for giving some insights from Luxembourg, we started to discuss some points also already yesterday. I fully agree with some of the points I tried to summarize. So I think also for Luxembourg, we are it's not only a rare disease, but we are a very small country. So we also see the registration seems to be very challenging because they collect everything, and childhood cancer is something specific. So it seems to be very complicated for them to really cope with. So this is something we are trying to improve, but I think having training where experts can share their expertise and also being very hands-on is very welcome, at least even also for Luxembourg. I can only underline this. Then we collected data for Luxembourg, so we do not have a specialized childhood cancer hospital in Luxembourg, so I think many also might go abroad. So aligned to GDPR and also our regulation, this is something we really have to investigate in, how many cases we miss, how many cases are going outside and coming back. And I fully agree, how could you do that? And then also, how can the data be shared? Because is that the parent who can agree upon that, or who is agreeing if you want to have an explicit consent to collect the data? However, what I can underline, I see from the government there is support, so they are interested, and there is interest. There are foundations in Luxembourg to support this. I think they really welcome all the support which can also be given from the international organization. So once again, thank you for that.
Thank you.
Thank you. So I don't know if there are questions from the people in the room or people online. So please don't hesitate to raise your hand or do some questions or comments.
Just was interested to come back to the same question. What are the current initiatives from the scientific community to tackle this lack of data?
Yeah. So as I showed, from our side, we are trying to target countries. For now, we have only 4, but we are probably going to expand to discuss with the leaders and with the professionals in the country how we can help. And so that's one, Child GICR, the project that I presented. And I guess for cancer registration, this is the main work that IARC is doing, but we are now supported by St. Jude, which is very good, but we would need much more support to be able to, and this is also why we are educating more people so that they can then educate others. So we are having next week a delegation from St. Jude who will come to IARC, and we are going to discuss how to best continue this collaboration and maybe scale it up. And then that's for Monday, Tuesday, and then the 3 other days there will be these trainers that completed masterclass who will come, and with them we will also discuss how to improve this, how to move this educational program further, and also some other more general questions about how, for example, how we could help them to support them to develop cancer registration or improve cancer registration or spread the knowledge, or what are their biggest problems and how to tackle them together.
Yeah, and maybe for Luxembourg, for example, we are also collaborating with the hospital itself to understand, how they collect, how they get the data if the child was being cared for outside of the country. We do also training with our encoders. We had some relationships with other countries to have experts here to support us to better understand. And then, of course, I think the largest discussion, how are we allowed to get the data? Because even if everyone is willing, the European GDPR is doing a lot of barriers there. So this is the biggest part of the current discussions, because even if everyone wants to get it, it's not that we are allowed to get it. So this is really something we are trying to put on a more larger political part, how we can extend our scope there. There are a lot of discussions, of course, ongoing, but then, as you already quite well mentioned, is we have such small numbers, so it's sometimes difficult to know how exhaustive are we, so we really need to collaborate directly with the patient itself, with the parents, and understand the context. So it's ongoing. It's what we started since last year, this is, I think, something we are continually doing, but initiatives coming from your organization are very helpful, because in the discussion to start them, we can show this is what we have to do, this is where we have to go. And then, of course, afterwards, we want to collaborate with some European or international associations to better also visualize our data, because, as you said, our statistical robustness is very low to show anything, so we have to collaborate there in really valorizing the data afterwards. Yeah.
Thank you.
Thank you.
So maybe I would still add, before Sophie asks her question, that we are I am very happy for this global initiative for childhood cancer, because even though it's very clinically oriented, it still helps us enormously. I mean, now there are a lot of activities that, childhood cancer gets attention, and this was needed. So that's one thing. And for GDPR, I wanted to add that some countries that are in Europe, they can send us the data. So it depends on the national interpretation of GDPR. And some countries are very, very strict. Nordic countries don't even exchange data amongst themselves. And some are in the middle. Then we have to do DTAs, the data transfer agreement, which takes a lot of time. And so it's a really nightmare. Yeah.
Yes, I was curious about who are the founders of this your Child GICR initiative?
It's St. Jude.
Only?
Yes. Well, we are contributing as well. Because our salaries are paid by the hour, so some of them.
Okay.
So
yeah.
So and it's like on annual basis.
Okay.
We do work, and then every year it's so far it was every year extended. So yeah.
Yes. Thank you very much for the very interesting talk. Please remind me, when you said cancer rates are being found to increase over time, was this general cancer or child cancer in specific, or both?
Yeah, these were, I think that they are all increasing, and probably overall even more than in children. But in children, the causes are not very well known and are not the same as in adults. We know, for example, smoking causes lung cancer. And lung cancer was, it's still the first cancer in adults. But in children, you need several decades to develop this lung cancer. In children, this is not possible. And because of small numbers, we have to do case control studies, and case control studies are subject to bias, and there are many problems with that. So there are some suggestions what causes cancer. The confirmed causes are ionizing radiation, some infections like EBV, or for leukemia there is a hypothesis that they might have infectious origin, but it is not clear whether it's all of them or some of them. And then there are some iatrogenic agents like. For example, we know, as seen, the second primary tumor is often or might be caused by treatment for cancer. So cancer treatment itself is carcinogenic. Mm-hmm. So these are the three areas where we know that these are causes of childhood cancer. We don't know exactly to what extent and what proportion and so on. And the others, there are many others: air pollution, pesticides. What else? The dietary factors that were examined, a lot of them, and the evidence is not quite yet established
Also because a lot of studies are, well, maybe do not have as robust design as would be interesting.
So the things you just mentioned that are some of the hypotheses that are put out for the
Yes.
increasing rates.
Yeah.
Because always it's interesting, the iatrogenic effect, is it more diagnosis, things like that. But always when there's a research conundrum like that, is it the iatrogenic or is it actual factors causing, there's going to be some
Yes,
saying it's all iatrogenic. So I was curious, you answered it very, very well, but I was very curious to know those who would say the rates are actually increasing, that it's not just an artifact of medical practice. I was curious to know what they hypothesize might be some of the reasons for the increase. So thank you for providing that list of candidates for that.
Yeah. I don't know how much of that increase could be explained by these exposures. But for example, that's why I think it would be useful to test or check each cancer type separately. Because for example, in a neuroblastoma, there was organized screening some maybe 2 decades ago, also in France, in UK, and especially in Japan. And so small children, the infants were checked for a neuroblastoma by some tests to detect neuroblastoma. And neuroblastoma is known to regress spontaneously sometimes. So, by this screening, the incidence rates increased, but mortality rates did not decrease. So then it was decided, okay, we are stopping this screening, but there is still some screening going on. Mm-hmm. It is not organized, but so the countries with high income who can do these good checks of infants, they show much higher rates of neuroblastoma. And we saw similar thing in thyroid cancer already in children. It's increasing, especially in countries where they are very active diagnostically.
And when we analyze over time, we need to consider as well that the technologies and to diagnose cancer is improving as well. Yes. And also as I have said to us during the presentation, that maybe they are also registering more. That this can be another factor.
Yeah, so I think it's multiple factors, but I don't like to say that it is just diagnostic because we know that for example, there are differences between black and white in rates of leukemia, and there were also some studies that were showing genetic links to getting more leukemia or less leukemia. So there are other factors, not just diagnosis, but it's difficult to quantify.
You're talking about risk factors, but it's during the childhood, since their birth, or it's also during pregnancy as well, because for kids below 5 years, the exposure time is very limited. So it seems unlikely that the dietary factor during this limited time could influence the cancer risk, but that may be completely wrong, I don't know. But so I was wondering if you thought so pregnancy was a vulnerable time as well.
Yes, very, very vulnerable. For example, there were studies that showed higher risk of hepatoblastoma with high birth weight. That means that there was something during uterine life that caused the child to develop this hepatoblastoma, because hepatoblastoma is tumor that is diagnosed in very early age. So it is almost sure that it was intrauterine development, or at least started to develop. And there are even some cancers that could be diagnosed during pregnancy, in the child. So yes, we think that there are studies looking at this, the exposure of mothers, also dietary exposures.
It could be also just bad luck as well, I guess.
Apparently, there was also
I don't know.
bad luck. Yes, of course. But that's even more difficult to study.
Yeah, sure. No, but if you can't explain, at least you can say probably just.
Because, for example, also supplementation by folic acid showed some reduction in risk in children or with Wilms tumor, which is renal cancer. And again, it's supplementation to the mother.
Yeah.
So there is definitely some role.
I guess it's very difficult to study anyway because of this ethical concern in studying pregnant women and baby. So it will be difficult to know.
I've got a question regarding the POX. So if I understand well, this is a way to estimate the number of survivors in childhood cancer, but you say that you could use this to estimate the number of survivors in low and middle income countries. Is it correct?
Well, that is not quite, it depends. I mean, we can if they provide the data that we need. So what is needed is incidence data by fine age groups and for relevant time periods. Then we need population data and also mortality data. And mortality data, I didn't show even that because it didn't fit in the scope of this, but mortality data are really, well, especially in low-income countries, for children it's not really available. Yeah, and where they are available, they are of limited interest. But we need them to calculate prevalence, and prevalence could, it includes people who are not children anymore. So yeah, if they provide all this data, then we can do it.
Okay.
But not,
Okay, so this model does not take into account access to treatment and access to diagnosis.
No, it's very, well, relatively simple assumptions. Everybody enters the stats. It's Markov model. I don't know if you are a statistician. So everybody is put on the cohort, and based on incidence rate in the first year of life, the proportion of people who are put in the cohort die, okay, or get cancer. So they can either get cancer or die. And if they get cancer, then we go to the next year and again impute the proportions of people who got cancer or died, and we continue like this. So I don't know. It's I am not doing these calculations, but this is how it works. So we need detailed data on incidence and mortality for each of the cohorts, and it's okay. The comparison was very good compared to when using individual records with proper data, but we saw for some cancers the agreement was less good, and of course again it's estimates. So yeah, so we assume that they are good also for all the other countries, but we don't know.
Thank you.
Thank you. Any other questions, maybe from people online? I don't see any comments or hands raised. Maybe in the meantime, I do also a question, maybe comment. What we have seen, so we have published the data for Luxembourg recently, and now we have compared them to estimates which are coming from international platforms, and we have seen quite big differences. So I think it's a bit what you were saying, depending on which estimate and which real world data you have, it was quite a big difference, where it's quite important to understand which kind of data is published and where it's coming from, because it fully can change the message you will give, because you are in a rare disease and the numbers are small, and depending what you do, so your percentage is changing a lot. So I think for Luxembourg this is true. People really need to check which kind of data have they taken to maybe do a bit more political statements. I think it's really something we can underline. And while looking at all your studies you are doing, it's something we have not touched at all, but it's about the survivorship for children, and there are some discussions in surrounding countries about the right to be forgotten. Is that something you are also considering at international level, or is it something you are discussing also in your studies, or how do you see that?
Yeah, so well, I think that if we want to do population-based research, we cannot have this possibility that people can get out from the data. What could be done? I mean, when we analyze data for each registry, that you need to have, I think, access to name, because the names is very important to match, you know, the next occurrence or follow-up status and so on. For us, but on international level, we do not need the names, but we want to have the full dates, because it also helps to. We help registries to improve their data when we check them, because they maybe do not have time and we learn. One registry has one kind of problem, very large problem. In other registry, the same issue is much smaller, but because we know that it can happen, we can check for it in all registries. So it's very important to collaborate. And I think that for Luxembourg, you are doing, it's very difficult, I think, because you have patients everywhere, you don't know where. And so I mean, I can only say good luck with getting all the information.
That's tricky, because we try to be more exhaustive as we can. And when we look to our data, you know, as Claudine said, we were doing some exercise. You know, the data that we have in the cancer registry is higher, like double of what is in the estimates. So, of course, we have a lot of change in the population as well, with the migration effect and everything. But yes, so that's something that we need to deeply look and investigate better too, because we are always saying, maybe we are not that exhaustive, but when you look, we have more data than what we would expect.
Yeah.
So that's what we want to understand better now.
Well, if you compare data with the Globocan estimates, I mean, they are maybe based, but they are not taking specific care about children. So it's they have overall cancer burden, which is split into age groups according to ICD classification. So if there are discrepancies, I would say it's not surprising.
Yeah.
But
Also,
if you have higher rates than what they predict, then I think it's a good sign, because that means that you know, you are catching more cases.
I had a comment or a question. In the artificial intelligence deep learning world, there is this new framework called federated learning, which allows to do federated analysis, and the idea behind it is that each node, each participating site of this federation would do the analysis, would not have to share the data with the other sites. So you would have your model to be trained on your data locally, and you would share your model with like a centralized server that would aggregate these analysis in the central server. Is this something, I'm mentioning this because this is something that is supposed to be very promising for the healthcare world, especially for rare diseases, for centers that have rare cases. Is this something that you have contemplated?
Yes, we did, and I think it's for us is not the method of choice, because of maybe because it's early stage, but it's like walking in the dark. You know, you have to have all the analysis done before you start looking into the data. You need to know what you want to look for. And for people who are working with data and do analysis, you know that it doesn't work like that. You look at the data, you are going for something, and then you see, but I didn't look at this one. There is something wrong with the data. You go back, you compare, you check.
So, and this federated analysis is like you don't know what is in that local data. So
you mean in the
in
participating
the
site?
node,
No.
the node, you don't know what is in the node.
In the other sites, no,
Yeah.
no. But the idea is that you would agree, like on how you will pre-process. Like there would be a shared, like framework on what kind of analysis is going to be done.
Yes.
The sample size per site, these sort of things are agreed on, and also the algorithm is designed accordingly. And so, say if you need in your model to put more weights on some nodes than on other based on population size, that is something is also taken into consideration in designing the solution. But I'm mentioning this because it could be something to tackle the data challenge. But I do understand that, yes, especially if when you're starting a new problem, like you need to touch the data, explore it before actually being able to propose like the appropriate solution.
And the quality control is
It's complicated.
it cannot be done, in fact, because you know, if you do not have the real data, you cannot really check.
No,
Everybody can check, but then yes, it's based on trust. But okay, we are losing something. We are not using all the data that is available. And in addition, for this type of analysis, you still need to go through ethical approval. You maybe need to pay. You have to have the same software everywhere.
You need to agree on this.
Yes,
things,
yes.
and you need to have
So
infrastructure.
All analysis as well. You need to have.
So it does not really reduce this administrative burden on getting the data, or maybe a little bit, because maybe it gets a little bit easier or possible to get the data, like from Nordic countries, which we cannot get at all. So maybe we can have access, but then, I think that we should still try to get the real data.
Yeah, for sure. But it's more like on a temporary solution towards getting the centralized. If you can't get the centralized approach working, maybe a federated way with one other center, big center, which is known to have more data.
Yeah. And also imagine, you know, like for IICC, we had 300 registries that were, and you know, it's like we first have to get all this agreement. All administrative procedure, then we get the data, and then we realize, okay, this data is not good. So, you know, all this work, and then you don't even use the data.
Yeah, well, that's why I said trust is important, because obviously the premise is that at each site there would have been the cleaning of the data, the proper data.
Yeah,
For
but
them
from my
to train the
experience,
model.
this is not possible.
Yeah, I'm not at that stage yet.
Any other questions, maybe from people online? I don't see any hands raised, because otherwise, in conscious of time, we do have sandwiches afterwards for people here. Please stay if you want. And for people online, thank you very much for joining. So the session is recorded. If you want to listen to Eva again, you can, as soon as we are putting it on our website. So thank you so much for joining. And I wish you all a good day today, and see you soon. Thank you very much. Bye-bye.